Good evening. Good evening. My name is Dr. Olushola Oluwashomkeni. I'm the medical advisor for Novo Nordisk for English West Africa. Today, we're going to be having a Basal Insulin Summit. It's part of our live webinar series. And our speaker today is Dr. Yakoba Atiasi. She's a senior lecturer, consultant physician at the University of Ghana Medical School. She's had several postgraduate trainings. She's a fellow of the West Africa College of Physicians. She's also had several postgraduate trainings in diabetology, a postgraduate diploma, and an MSc. She's published in several peer-reviewed journals internationally and locally, and she will be taking us through basal insulin today. Please welcome Dr. Yakoba Atiase. Thank you.
Thank you. I'm trying to get my slides on. Give me a moment. Can you see my slides?
Not yet.
Okay. Present.
Welcome, Dr. Yakoba.
Share screen. Entire screen. Can you see it now?
Yes, it's coming up.
Okay. Sincere apologies. Can you hear me very well?
Yes, please. You're loud and clear.
All right. So this afternoon, thank you very much for the introduction. This afternoon, we are going to look at the evolution of basal insulins and see that with the evolution of insulins, and particularly basal insulins, scientists have been able to approach almost physiological and PKP, dynamics of basal insulins. We'll look at insulin, what it is. We'll look at what basal insulins are and what they do. We'll look at the ideal basal insulin, and we'll look at a molecule that is close to ideal, if not ideal, and we'll look at the initiation and titration of that molecule. In 1921, a 14-year-old boy called Leonard Thompson was on the verge of death. Before him, every child who had had diabetes, type 1 diabetes, had died. He had been in hospital for so long, and it is documented that he was weighing, at 14 years, he was weighing 65 pounds. That is less than 30 kilos. After several months in hospital, his physicians decided that they would try and use an experimental drug that had just been discovered also in his home country, Canada. Previously, this new experimental drug had been used on animals, on dogs, who had had a pancreatectomy and developed diabetes. When the extract from their pancreas was injected back into them, they noticed that their blood glucose came down remarkably. And so even though it was experimental, it was thought that that would give this young boy a chance. Within a few days of giving him this murky solution from the pancreas of a dog, this boy started gaining weight. His blood sugar started coming down, and he lived for several years. Leonard Thompson lived several years, and that was a turning point for managing a disease called diabetes that had otherwise been a death sentence, particularly type 1 diabetes. The two gentlemen you see on your screen are Leonard Banting and Best, they are the ones who performed the first pancreatectomy. And this dog made him diabetic and injected his own pancreatic fluid back into him and noticed that his blood sugar came down remarkably. So that is the story of insulin, and that is a story we all know as insulin, the lifesaver. What would we have done without insulin? So what is insulin? Insulin is a peptide hormone that is exclusively secreted by the beta cells of the pancreas, and it is responsible for carbohydrate, fat, and protein metabolism. What insulin does is that in carbohydrate metabolism, insulin increases glycogen synthesis from glucose. So if your blood glucose is high, insulin will push your blood glucose into your liver and cause it to be converted into glycogen. Insulin will also increase blood glucose uptake into your cells, into muscle, into adipose tissue. Insulin, importantly, will also decrease the new formation of glucose from the liver, and insulin will inhibit glycogen breakdown from the liver into blood cells. So you can imagine that if you don't have insulin, then all these will be in the reverse. There'll be a decrease in glycogen synthesis leading to hyperglycemia. There'll be a decrease in glucose uptake in cells leading to hyperglycemia. There'll be an increase in gluconeogenesis leading to hyperglycemia. And there'll be an increase in glycogenolysis also leading to hyperglycemia. And that is how Leonard Thompson had his hyperglycemia. He had no insulin. The other important thing about insulin is that not only does it clear triglycerides from blood, but it inhibits lipolysis. So the absence of insulin causes lipolysis to go on. And we all know that the byproduct of lipolysis is the formation of acids, acetoacetate, acetone, ketoacids that can be dangerous to human beings, what we know as diabetic ketoacidosis. Insulin also inhibits breakdown of cells. And so when a person has no insulin, there is the likelihood that they will lose so much weight as we saw in Leonard Thompson. And insulin, because it inhibits breakdown, is anabolic. It causes weight gain and increases amino acid uptake by the cells. So this is a structure of insulin. It's like a necklace. So imagine two beads or two strings of beads. Each bead represents one amino acid. Insulin and the beads are joined rather than joining at the neck like we wear our necklaces. They are joined at specific points on the bead level. In insulin, human insulin, two cysteine so there are two amino acid chains, A and B, from A7 and B7. There are two similar amino acids. They are joined from A20 and B19. They are also joined, and also on A8, A6 and I think 11 or so, they are also joined by disulfide bonds, making them very stable in circulation. Insulin evolved from the dog as we showed earlier, but how many dogs can we kill when there are cows and pigs being killed for consumption? So at the time, insulin was taken from the pancreases or the pancreata of animals being slaughtered in abattoirs. They were refined, and that is what we injected all along. Now, it's interesting to note that until 1980, which is not too long, I was already a young girl then, until 1980, insulin was extracted from animal sources. But at a point, it was realized that they were getting a lot of allergies, reactions in human beings. And so it was thought that insulin should be extracted from human beings. And so cadaveric human beings, the cadavers were taking, pancreases were taking out, and the extraction was made. But how many human beings can one take to extract insulin for all the people who need insulin? And so there was a thought that, well, we could put insulin in a vehicle that can sort of build or produce more insulin. And so scientists thought, how about putting it in a rapidly multiplying agent to become an insulin factory? This was thought that, well, bacteria like E. coli or yeast rapidly multiply. And so now, if we take the human insulin and we give it a potential, an instruction as to the amino acid sequence we wanted, each replication or each multiplication of a cell, E. coli or yeast, will produce a certain amount of insulin, and that could be extracted, purified, and used. And that is what we know as the DNA recombinant mechanism of producing insulin. Human insulin was taken, put into a vehicle, E. coli or yeast, and allowed to multiply. Insulin was extracted, purified, and given to human beings. Later on, it was realized that, well, human insulins are good, but most of the time they were short acting. So we had to find, we were taking several shots of insulin a day. We had to find a way of making it different. We had to find a way of also making the mechanisms different because we needed different insulins for different times of the day. So it was realized that if we change the size of insulin, the mechanism of action will change. If we change the charge on insulin, it will also change. If we change a certain element or we altered the amino acid sequence, it is still the human insulin, but with a little change, and it will act differently. And so came the analog insulins. The analog insulins are basically human insulins, same amino acid sequence, but sometimes they take one amino acid out, for maybe from A1 is taken to A5. So same sequence, but it's been altered a little bit, it's been tinkered with a little bit. And the mechanism of action changes into either becoming rapidly acting, short acting, or becoming very long acting. Now, so at the time, we realized that we can't be giving insulin so often and so frequently. So the other thought was that, can we produce insulin that would last so long so that we don't have to inject so frequently? In 1936, the first basal insulin was produced, and it's still available in use even now, even in Ghana. Now, what they did was that they added protamine, which was a bulky structure, to human insulin, and that suddenly changed the duration of action from short acting to long acting over 20 hours, ensuring that patients needed only once or twice daily injections, which was welcome at the time. Ultra lengthy in 1954, they added zinc to it, made it 24 hours. And that's what we used for a very long time until 2000, when the star of insulin therapy came, the analog insulin that could form microprecipitate at a neutral pH in the injection site, lasting over 26 up to 23. Some people say 23, 18 to 26 hours, depending on the literature you're looking at. But we know that 24, 25 hours maximum, it will stop working. And that's an important point to note, because you realize that because it's lasting for up to about 24 hours, then it means that at a particular time you must inject, otherwise there's a gap in your insulin therapy. And if you have type 1, for example, it can lead you to diabetic ketoacidosis. Now in 2004, insulin degludec also came. The method of protraction was to form dihexamers, and these dihexamers were inserted under in the subcutaneous tissue. They bind to albumin at the injection site and are released slowly and absorbed. Now, in 2013, the IDEG, which is the current insulin that we know, forms multihexamers in the depot site. And these multihexamers now form stable dihexamers. And as the phenol and zinc, dissociate from the site, and I'll show you a video of it, gradually the monomers are released and absorbed and used in the. So this is a history of insulin. From Leonard Thompson, went down to animal production, commercial production of insulin, human insulin. We got to human analog, and now what we call the next generation of insulins, which include Insulin Degludec, which we'll discuss shortly. It's important to remember that insulin secretion is not physiologically, is carefully orchestrated. We have the basal insulin, which consists of rapid pulsatile release of insulin from the pancreas throughout the day, but never high enough to cause hypo. So basal insulin should not cause hypoglycemia because very small, frequent doses of insulin are being released throughout the day. Then when we eat and our sugars go up postprandially, there's a stimulation of insulin. The first phase is insulin that has already been formed, preformed, and already there in circulation. It is released within minutes after eating. And then if after 10 minutes of eating, your sugar is not coming down to normal, then phase two, where there's new formation of insulin, which lasts longer and is slower acting. And that brings your blood sugar levels back to baseline. And that is important. But today we are focusing on basal insulin. So what is the role of basal insulin? The role of physiologic basal insulin is that it is nearly constant. If you look at the graph here, I'm not sure you can see my cursor, but on the green graph, you can see that there's a basal secretion of insulin and it's flat. It doesn't spike. And when you eat, glucose goes up, then you see the first phase insulin secretion and a new little high production of insulin in with every meal. You can see lunchtime probably had a higher amount of blood sugar, and so at lunchtime the second phase blood sugar and insulin production was much higher. Now it's important to understand that basal insulin suppresses glucose production between meals. So just before your next meal, it is basal insulin that is responsible for the blood sugar you see. And it is important to also understand that approximately 50% of your daily insulin needs are from your basal production of insulin. And so when you are replacing somebody's insulin, it's a patient who hasn't got any insulin, it's important to keep that in mind. If you are using basal insulin, remember that basal insulin controls the fasting blood glucose and the preprandial glucose. Whatever you add to it is responsible for the postprandial hyperglycemia that you will see. But your basal insulin will control the fasting blood sugar and your preprandial blood sugar. And remember that even when we are injecting, typically we say that approximately 50% of that should be basal insulin. Now, insulin is a very important diabetes medication. If you look at this, and there are newer medications that are not on this slide. However, you can see that whilst most of the medications can reduce your HbA1c by about 1.5, insulin can do way more than that. It can come from 13 to 7, 6. It will bring your blood sugar down, especially if the patient is not drug naive. Now, if a patient is drug naive, you can come from very high blood sugar levels and come to normal. But if a patient is not drug naive and their HbA1c is at 13, it's not likely that any other medication can bring it down to normal. We've heard this over and over again. Don't be glucocentric when you are managing diabetes, and it's important. Of course, you have to look at their blood pressure. Of course, you have to look at their weight. Of course, you have to look at things like cholesterol. But remember that even though we say don't be glucocentric, blood glucose levels are important because blood glucose levels are closely associated with the risk of microvascular complications, blindness, nephropathy, and neuropathy. And these are important, they affect the quality of life of patients so much. And so even though we are glucocentric, glucocentricity is not a bad thing after all. Just don't forget the other things you have to manage. Now, glucose is important. Across the globe, most countries are not doing well. Our HbA1cs, even though we have established that getting an HbA1c below 7 is useful to prevent complications of diabetes, across the globe, no one is able to achieve that. Some countries are doing better than others, and we in Ghana, recent annual population studies, small studies, show that our patients' mean glycemic HbA1c is between 8 to 9%, which is terrible. So we must find a way of getting our blood glucose levels to normal. And this is true for both type 1 and type 2 diabetes. So let's look at the ideal basal insulin. The ideal basal insulin must have certain characteristics, and that's why we are here this afternoon. It must be able to control blood glucose level, and as I've said, fasting plasma glucose and preprandial glucose. Now, even though it doesn't control postprandial glucose, if you are able to get your fasting blood glucose down, it is likely that the glucose excursions postprandially can also be managed better. And I'll explain that later on. The ideal basal insulin must also have a low risk of hypoglycemia. And hypoglycemia is a big issue. We'll have a look at it in subsequent slides. Now, it's an injection. Nobody likes injection. And so the ideal basal insulin physiologically is being produced constantly in the background. But we cannot give constant insulin in the background unless you have an insulin pump. So at the very least, we ask that the ideal basal insulin be given once a day with the possibility of flexible dosing. And the action profile should be as flat as you see in the cartoon in the bottom right corner. Thankfully, most basal insulins from MPH that was done in 1939, discovered in 1939, to the ones that we have on the market are able to improve glycemic control. However, there are limitations. In the past, it was shown, and it's still true, if you want to get your HbA1c to target, you must, of course, fix your fasting plasma glucose, but you must also fix your postprandial glucose before your HbA1c can also get to target. And this is important. We will not say that one is more important than the other. But there are many things that must also be considered, and we'll have a look at it in a few moments. The real challenge is not about glycemic control. As I said, almost all basal insulins are able to do that. The real challenge is to do that with a low hypoglycemia risk. And so balancing hypoglycemia and hyperglycemia to get a good balance of good glucose control is a challenge with basal insulins or insulins in general, or even with managing patients with diabetes. Hypoglycemia, as we know, is a big barrier to good glycemic control. If you have a patient who's had a severe hypoglycemic episode, one that maybe required him to be rushed to hospital, I can assure you that that patient, for a very long time, you'll find it very difficult to get him on target because he's going to skip his medications for fear of hypoglycemia. He will not take it. In fact, sometimes it's not the patient's not taking it. The doctors themselves are so scared that they reduce the dose significantly, giving them suboptimal dosing because of a fear of hypoglycemia. Sadly, approximately 90% of all patients with diabetes on insulin have had a hypoglycemic episode before, and that's scary, which means that it is likely that our patients, out of fear, are either not adherent to medication or are on suboptimal doses themselves, or we, the physicians, are actually out of fear giving them suboptimal doses. Now, the consequences of hypo is not just, you got a hypo, you are afraid to inject. There are other direct and indirect, things we must consider. You get a hypo, suddenly your doctor becomes paranoid or not paranoid, starts tagging you as high risk. So now you're going to do more frequent monitoring of blood glucose. So you're going to incur some costs in terms of buying glucometers or, continuous glucose monitor. You're going to probably go to the hospital more often. When you had the hypo, you probably were rushed into emergency, you were hospitalized, you took some days off. The risk of hypo, sometimes I wonder whether all these patients, these unnecessary accidents on our roads are all due to some of these things, but we don't have documentation for that. So the consequences of hypoglycemia is a burden on us as a society and to our patients as well. The other important thing about hypoglycemia is that it is not just the hypo. The neuroendocrine response of a hypoglycemia can expose a patient to a lot of complications. On the CNS, it can cause, if you get frequent hypoglycemic episodes, you are likely to get cognitive dysfunction later on in your adulthood. The risk of seizures and comas, falls, fractures and dislocation, accidents, and the fear of hypo, as I've mentioned, become important. But also, the autonomic or the adrenergic response to hypoglycemia can lead to an increased risk of cardiovascular events, particularly cardiac arrhythmias, because we know that the autonomic response leads to tachycardia. The tachycardia in a heart that is primed or is at risk of arrhythmias can trigger a very bad arrhythmia. It can lead to myocardial infarction In fact, it's been shown to cause hemodynamic changes and cause endothelial dysfunction, which we know is a beginning of cardiovascular events. And so hypo is not just you've got a hypo, we've corrected it. Once you get a hypo, in fact, some small studies have shown that the patients get hypo, they can have ECG abnormalities lasting several days. It triggers inflammation and may increase a patient's risk of, I said, cardiovascular events. Across several cardiovascular outcome trials, and after a few years ago, several years ago, actually, it was required that every new medication that was being given to patients with diabetes, not only must they show that they have good glycemic control, but because, especially in type 2 diabetes, because cardiovascular events are the predominant cause of death in these patients, it should not increase their cost. Now, when these CVOTs were done, it was shown that across a large spectrum of CVOTs, you realize that hypoglycemia was associated with major adverse cardiovascular effects and all-cause mortality across these CVOTs. So hypoglycemia is a big issue. If you're giving your patients or you're managing your patient, you have the option to choose a medication that will not cause hypo, especially in people who are at risk of hypos, an elderly patient, people you think will have the effect even more, then you want to ensure that you're giving them medications that have a low hypoglycemia risk. So hypoglycemia, we said that hypoglycemia is a big limitation. As for glycemic control, they all do it well, but you must do it in a way that you are not limited by hypoglycemia. Hypoglycemia is a limitation, even in basal insulin administration, which has generally a low risk. The other limitation in the use of basal insulin is that until recently, if your doctor tells you inject your insulin at 7 p.m., you must inject it at 7 p.m. every day. How many of us are sure where we'll be at 7 p.m. at the same day, or whatever time you choose, 11 p.m., 12 noon, whatever time it is, until recently, the injection must be administered at the same time, and that is a limitation. Most basal insulins do not fully cover the 24 hours, and so it becomes a challenge. In fact, a lot of patients said that they found that they had to plan their life around their medication, and that was bothersome to them. 28% of patients have been said to say that they find it difficult to take insulin prescribed at the same time with meals every day. And so we must make it easier on our patients. If I can take it at 8 p.m. today and tomorrow I get home late, maybe Friday night I've gone out or you've gone for a funeral, you didn't get home at the set time, you should be able to give yourself the injection without fear of a gap in your medication. And so medications that cover longer than 24 hours are ideal as they offer some flexibility for our patients. Now, several patients, we know that insulin is being missed or is not taken as prescribed. Several patients have said that they omit insulin at least one day in a month with an average of about 3 days. And 73% of physicians reported that their typical patient does not take their insulin as prescribed. I know that for sure. Most patients do not take it. There are a few patients who are very good, they take it, but by and large, a few of our patients miss doses or intentionally reduce the doses. Why do they do that? Business, they're traveling, they forgot, you rush out of the office or rush out of home and then you realize I didn't inject, there's so much traffic, you can't come back. So that's, it's gone for the day. And sometimes the regimen we give them are too complicated. The once daily injection is usually useful if it will control their blood sugar. The important thing is that 9.4% of them said that it was too much of a challenge to inject at the same time each day. So these limitations are due to, especially the limitation of administering at the same time each day, are due to the fact that the duration of action and the half-life of most of the insulins, basal insulins on the market is short. And so it doesn't cover very well. So therefore, if you have an insulin that is very physiological, it must have a very long half-life and it must have a very long duration of action to offset this kind of limitation. There are other limitations. There's something we call high glucose variability, and I'll talk about that in a moment. Reducing variability is very important to ensuring that our patients are well controlled and have a low risk of complications. So what is glucose variability? Glucose variability just means swings in blood glucose. We can have within the variability. So some people break before fasting is 5.6. Before dinner, which is also interprandial, is 8. Before lunch is 12. Nothing has happened. That is within day variability. Then we have day-to-day variability. There are patients on the same medication eating the same food. Every morning, fasting blood sugar is 5. Meanwhile, there are some patients, today is 5, the next day is 12. At the same time, same food eaten the day before. That is day-to-day variability. Now, within the variability, it means that you have hypers and hypos throughout the day, and that is dangerous. I'll show you in a moment. Then you have the day-to-day variability. That means that there's a variance between days of the same individual at the same time each day, and that is not to be encouraged. As much as possible, we must reduce the variability of, glucose variability of our patients to almost negligible, and that ensures that their risk of cardiovascular events and complications is much reduced. So this is a typical picture of a patient who has a wide variability. Look at this patient. He's not in target at any point in the day. At one time, blood sugar is high, it goes high, and rather than getting into the normal, it goes straight into hypo, and they are swinging all over the place. Both of these patients have an HbA1c of 7.8. It is important to remember that HbA1c alone is not enough, because you can have a patient who has an HbA1c of 7.8 and another who has the same HbA1c of 7.8. For this one with the swinging or the high variability, you probably have to reduce his insulin dose if he's on insulin, because he's getting a lot of hypos. So you have to stop that. But for the one who is near target but also has an HbA1c of 7.8, it's important that you tighten his control so that his HbA1c is within target. So glucose variability is important. But importantly, from the glycemic triad I show you with HbA1c, fasting plasma glucose, and postprandial glucose, now we don't look at the glycemic triad anymore. What is important is what is called the glycemic pentad. And the pentad, in addition to the fasting plasma glucose, postprandial glucose, and HbA1c, includes glycemic variability and hypoglycemia. It's been shown that a wide variability, glycemic variability, predicts coronary artery disease. So your patient who is at risk of a coronary artery disease or has had an MI, you must ensure that they are not getting a wide variability. They are within, a certain set target. Otherwise, their risk of events is much higher. But so is fasting plasma glucose. Fasting plasma glucose is also associated with CV mortality. Okay, HbA1c, we know that the higher your HbA1c, the higher your risk of complications, particularly microvascular complications. But if in addition to that, your blood glucose, your blood pressure is not controlled, your lipids are not well controlled, then your risk of macrovascular complications will also increase. Now, postprandial glucose also independently predicts cardiovascular risk, but is associated with things like also blindness and cognitive decline. And hypoglycemia is linked with a 70%, 79% increased rate of acute cardiovascular events, especially in the acute phase of that hypoglycemia, and must be avoided. Glucose variability has been shown to predict future risk of hypoglycemia. If you are a patient, your patient is swinging from one end to the other and the variability is wide, it is likely that at some point, as you intensify your treatment, they are likely to get a hypoglycemic event. Variability is also important because, as shown in this study, is an independent risk factor for mortality. Now, when variability was shown to be maybe 8.5%, which is fair, you can see that survival is much higher. As variability increases, survival reduces. So variability is important. When you're choosing your insulin, you must choose an insulin that is likely or close to physiological, as we've said, so that your risk for hypo is much reduced. In the development of an ideal basal insulin, not only must you have clinical benefits, as in good glycemic control, which most basal insulins have, but you must have a long duration of action so that you can control your fasting and your interprandial insulin with one insulin injection. You must also have a flat time action profile, and importantly, you must have less day-to-day variability. This ensures that you are not swinging from hypers to hypos, and that is important. Now let's look at the molecule Degludec. Just like I showed you in my first few slides, Degludec is similar to, in fact, is the same as normal insulin. You can see 21 amino acids in chain A and 30 amino acids in chain B. The amino acid sequence is very identical to human insulin, except for the removal of threonine at the position 30 and the addition at position 29 of a large glutamic acid spacer, which makes it very stable and which also ensures that it forms the hexamers, the multi-hexamers that I said, so that patients can have a long duration, the insulin can have a long duration of action and sequential secretion of the monomers in circulation. In addition to that, there's zinc and there's phenol in insulin degludec. And when these, I'll show you in a few moments, when these dissociate, it causes the multi-hexamers to also dissociate and release the monomers into circulation. So when insulin degludec is administered, it forms stable dihexamers in circulation. These dihexamers adapt and form a single chain, and you see that in a moment. You have the fatty acid chain on the side, you have the phenol on the side, you have the zinc on the side. They form a single large chain. Immediately after that, you see that as the zinc and the phenol start dissociating, so you see it, they form the zinc and the phenols dissociate, then the large chains form. Then you see that zinc starts dissociating and the monomer starts being released slowly in circulation and absorbed into blood for the effect to be done, to take place. This property that I've shown you in this video would make degludec close to the ideal basal insulin. It controls glucose, but it also offers it, gives with it a low risk of hypoglycemia. Degludec, glargine was the drug of choice before degludec came. And you can see in this study, which I'm showing you here, that both of them have good effective glycemic control, but in real world evidence, it was shown that degludec has a lower rate of hypoglycemia. And actually, you use lower insulin dose of degludec compared to glargine. And that may offer it some cost effectiveness when the price margin is not too much. The other important thing is that the half-life of degludec is twice as long as that of glargine. The half-life of degludec is about 25 hours, but the half-life of glargine is 12 hours. That translates into a lot. Now, what that means is that you can give degludec without what we call stacking, and I'll try and explain. If you have a patient and you give them a dose of insulin degludec, remember that your half-life is 24 hours or 25 hours. At the end of 24 hours, because the half-life is 24 hours, let's say it's about 25, you would have lost half of the injection that you would have given at time 0. So you have 5 units left. The next day, you give yourself another dose of 10 units, which is what your doctor has prescribed. There will be half of the 5 left and half of the 10 left. That will be 7.5 units left. By day 3, you are getting close to 9 units of insulin. So it's important to remember that when you give your patient a dose of degludec, it will take about 3 days for you to see the effect of the dose. So you don't increase the dose within a day or two just because the patient's sugars haven't reached, where you are expecting it to go. Because of the half-life, it takes a long time, 3 days, for you to get to a steady state of insulin levels. And by day 4, you have 10 units given on day 4, because the day before now you are reaching steady state and you have 9 units. By day 4, you have 10 units, and subsequently, the half-life of 10 remains 10 constantly. And that's important because it ensures that there's no stacking of insulin. Some other insulins do not have this mechanism, and they can stack and increase your amount of insulin in circulation and cause hypoglycemia. In both type 1 and type 2, the steady state concentrations have been shown to be about 3 days. So please, if you are given a drug like Degludec, do not rush. The patient calls you, doc, my sugar is still 20 or my sugar is still 15. Don't panic. Let's give it a few more days. We increase it once a week or maximum every 4 or 5 days. Now, it's also important that we know that routine is important in patients with diabetes. In fact, I have a patient who recently told me that, doctor, me, I'm not OCD. I can't do this thing that wake up, do this, do this. My life happens as it happens. So this kind of, you have to do this at this time. And this patient, of course, is poorly controlled. It's important to realize that even though routine is important, even for those who have the so-called OCDs my patient was describing, it is not always possible to inject at the same time each day. It is not possible. You will be late, you'll be caught in traffic, you won't get home at the correct time. If you can, then it means you are carrying your pen along, which you can, but most patients are not able to inject at the same time. For example, you're having your wedding, there's a jam going on. How do you stop and go and inject because it's time? So on occasions when administration at the same time is not possible, if you're on a drug like Degludec, it allows for flexibility in the timing of your insulin. And for patients like that, this is what is required. I remember a few years ago, I had a patient who had big man, big board, big company, CEO of a big company. He was on a premix insulin. And he says, Doc, the medicine they gave me is embarrassing me because I'm taking it in the morning and by lunchtime I have to eat. Otherwise I get a hypo. So I'm in a serious board meeting. They are talking about serious things and I'm looking around asking when lunch is coming. It makes me look as if I'm not serious. Can you change it for me? Of course, a basal insulin was given at the time. He was switched from premix to basal bolus, and he was ecstatic because now he only ate when he was, he had to. He only took his injection when he knew that there was food around, and he was assured that he wasn't at risk of getting a hypoglycemia. So, in addition to good glycemic control and low risk of hypo, the ideal basal insulin must be offered at once daily. Most of them can do that. But there must be the possibility of flexible dosing. When you are able to do that, the patient is likely to be adherent. This is my patient who says he hasn't got OCD and he can't do that. This gives him the flexibility. He's in a meeting, he's late, he says he can't inject at the same time every day, and he's happy with his new insulin. So the long half-life of Degludec means that even if a dose is missed, the patient is covered. I mean, the long duration of Degludec rather than the long half-life. The long duration of Degludec means that even if a dose is missed, the patient is covered. So for those who don't have OCD in quotes and cannot, be fixated, then Degludec is your drug of choice. The other thing we spoke about in terms of the ideal basal insulin is variability. Degludec has a low glucose variability, and compared to glargine, it's been shown, according to this study, that there's 4 times less variability with insulin Degludec compared to insulin glargine. And insulin Degludec provides 4 times lower day-to-day variability compared to the competitor glargine on the market. So let's compare the various basal insulins as we come to a close. We have NPH here, it's still available in use. We have glargine, we have Detimir, we have Degludec. The structure is similar. They all have the insulin, the basic insulin and human insulin structure. NPH has protamine and zinc, making it heavier and releasing it slowly. Glargine has addition of 2 and substitution of 1 amino acid. So their insulin, they have a bigger amino acid sequence. Detimir has addition of an acetylated fatty acid to the regular insulin. And Degludec, I said, there's a reduction of deletion of B30-309 at that point, and the addition of the glutamic acid spacer that stabilizes it and makes it able to form the multi-hexamers in circulation to be released later on. The first 2 do not have any carbon side chain, but Detimir and Degludec have carbon side chains. The mechanism of protraction is what we've said. There's less solubility in the extracellular fluid. There's precipitation at hypoglycemia at acidic pH. There's binding of albumin for Detimir. And for Degludec, there's multi-hexamer chain formation at the site of injection with subsequent release of monomers at the site, causing slow release of insulin into circulation. The terminal half-life is variable for MPH, and that's what makes MPH quite the unpleasant one to use, because you inject it, you don't know, it has to be injected particularly in the evening. The others can be injected during the day, but for MPH, you must inject it in the night time. But because it's so variable, the risk of hyper and hypers is very, very high. The terminal half-life for glycine is 12.5, for detamir is 12.5, but the half-life of degludec is over 24 hours. The duration of action, 20 hours, up to 24 hours, 18 to 23 hours, but up to 42 hours, allowing you the flexibility of not injecting, even if you miss the dose, you'll be comfortable wherever you are. The variability is the lowest in degludec compared to the others. The variability of glycine is much higher. Even detamir is lower than glycine. And the exposure ratio is 6:4, where because of the half-life, you have 50-50 at any point in time. The timing for MPH is given once a day, but in people who don't have very good glycemic control, we can increase it to twice a day. And glycine is also once a day, but because it's up to 24 hours, it is usually recommended that you give it at the same time each day. And detamir is given once or twice daily, especially when the doses get to very high, the dosage gets higher, then you increase it to twice a day. But with degludec, because of the long duration of action of 42 hours, you can inject at any time of the day. For example, today I know I won't come home early. I can decide, okay, let me inject. Or I miss the dose when I come back, I get home at 11 p.m. or midnight, I can inject. I know I'm covered. The risk of hypoglycemia is the least in degludec. The risk of nocturnal hypoglycemia is also the least in degludec compared to the others. The risk of severe hypoglycemia, when we say severe hypoglycemia, it has nothing to do with the number on the glucometer. Severe hypoglycemia is determined or is defined as a hypoglycemic episode that requires another person to help you correct. So if you are confused, you don't know what to do, if a normal, if I'm getting a hypo now, I can feel it, I can take something, put it in my mouth. That's not severe hypo. But if I'm so confused, they have to come and take me and rush me somewhere, or my family members have to come and give me something to drink because I'm so confused, that's a severe hypo. For most of the time, injection site reactions, to be fair, these days you hardly ever see them. But according to this data, it's possible because of the acidic pH of glycine. And there's weight gain in all the insulin is an anabolic drug, and we say that it causes protein, it inhibits protein breakdown and all that. So there's weight gain in all, except it's a very low risk of weight gain in detamir. All right. It can be used in renal impairment. Both need to be done. You can use it all three in renal impairment, except MPH, when you have to consider serious dose adjustment. In hepatic impairment, MPH cannot be used, or you have to consider the dose. It can be used with glucagon-like peptides, both glycine and degludec can, but not detamir, and it can be mixed with other rapid-acting insulin. Okay. Now, I just wanted to bring this to show you that basal insulins are important, and this is a picture of the Ghana Diabetes National Diabetes Guidelines of Diabetes of Ghana. If you didn't know we had our guidelines out, I'd encourage you to go to the DEMSOG website, DEMSOG. It's available for free, and get a soft copy for your use. Now, the National Diabetes Guidelines says that when your patient is poorly controlled, you're on metformin, you're on a second option, you're on a third option, still not controlled, and you have to start insulin, the recommendation, not only for our guidelines, but in other international guidelines, is to consider a basal insulin. If you want to promote weight loss, you should also consider a basal insulin compared to the other options. So basal insulin when insulin is mentioned for the first time, it runs. Even when we say reduce cost, we mention a basal insulin and not a premix first. A basal insulin, but if cost is a problem, then MPH is much cheaper and is on the national health insurance and can be used. So The important thing we say is that make sure that in a patient with hyperglycemia, fix your fasting first. For example, you have a patient whose fasting plasma glucose is 8. Of course, if the excursion is +4, for example, it is likely that after they eat, their postprandial glucose will be 12. The same patient, let's reduce their fasting plasma glucose to, let's say, 4.8 or 5. Adding the same 4 excursions, the same meal they are eating, they will get to around 9. So it's important that you fix the fasting first before you attempt to fix the postprandial. And that is a teaching when you are trying to intensify, especially when the patient is on insulin. How do you initiate insulin degludec or switch from other basal insulin? In type 1, of course, you have to weigh the person. You have to, maybe the person has come off some sliding scale or whatever you're doing. You have to calculate and determine how much insulin the patient will need. But it's important to remember that in type 1 patients, not only do they need a basal insulin as is physiological, but they need a mealtime insulin. If you just give them a basal and do not give them mealtime insulin, they'll have postprandial hyperglycemia, and that can be dangerous for them. The recommended daily starting dose is in accordance to the individual needs, the weight, what they are eating and all that. And then you start at a small dose, and then you can titrate as the days go by. However, sometimes you would want to switch from another basal insulin. If they are on another basal insulin and it's once a day, the unit dose is 1:1. If they're on 10, insulin X and you're switching to Degludec, you switch to 10 on Degludec. If they are on twice a day, remember one of the slides I said that there is the chance that your insulin requirement will be low. So if that is the case, then you may want to do a 20% dose reduction before you adjust upward if need be. In type 2 diabetes is the same. You can administer it alone. You can administer it in combination with other medications. They are on oral medication, they are on metformin, they are on DPP-4 inhibitor or GLP-1 or SGLT2 inhibitor. You add it to it. The recommended daily starting dose is 10 units. And subsequently, after every 4 or 5 days, you look at their fasting plasma glucose and their preprandial blood glucose, and you adjust the dose. Typically, we will say you don't look at just after you've done the monitoring. You should look about 2 or 3 days and decide that, okay, this is a range. Then you want to add on or reduce it. If you are switching from another basal insulin, if it's once a day, it's unit to unit switch, just like type 1. If it's a patient who is on a twice daily insulin, let's say Detamir or MPH or something else, you want to do a 20% dose reduction in the dose you are giving this patient, and you switch it effectively. Now, we advise a once daily titration. Remember, I said that it take about 3 days or let's say 4 days for you to get your steady state. Now, after the 4th day, that is when it's like day 1 of steady state. So you add a few more days, another day or 2, to see what your sugar levels are. And based on that, you can add on. If a blood glucose is above target, and these targets should be set by you, fasting plasma glucose, you can decide that your fasting plasma glucose should be 5 or 6 or 7. Or an elderly patient, you want to do 7 point, whatever you've decided. If you're above the target, then you add 2 units to your once daily insulin degludec that the patient is taking. They take it for another 3 days, you receive steady state, you reach steady state, and then you observe for 2 or 3 days. That's almost a week before you can increase again. If you are at target, you maintain the dose that you are on. And if you are below target or you are now getting hypos, then of course you have to take away 2 units from the dose you are already being given. And your fasting plasma glucose targets, like I said, should be individualized. In fact, with the management of type 2, with management of diabetes, glycemic control is always individualized. Your glycemic target will be different from my glycemic target. Or my elderly aunt I saw this afternoon, whose HbA1c is 7.3. I'm quite happy with it. She's 92. So 7.3, 7.5, I'm quite happy. But if I see a medical student, a young person, blood sugar, they have so much ahead of them. If their blood sugar is 7.3, no, their target will be much tighter. I would try and get them below 7. And if I'm able to get to 7, then I may even try 6.5 and tighten it, all the while making sure that their risk of hypo is low or negligible. Okay, so the target is between fasting target is usually between 4.4 to 7.2. Okay, depending on who you are seeing. So it's a wide range, and you must determine what target you set with your patient. So I'm coming to the end of this afternoon's presentation. Insulin Degludec has been shown to be the insulin that has, reached almost physiologic insulin, status. And it does this by forming multiple hexamers after subcutaneous injection, from which insulin monomers gradually dissociate and go into circulation. It provides the flattest curve of all the insulins, and it's stable. It has a stable glucose lowering effect and is distributed evenly, inequally over 24 hours. When it comes to glycemic control, compared to glycogen, which was previously the standard on the block, it's non-inferior, as the same as it, and it does so with a significant lower rate of hypoglycemia, and then the ability to dose in a flexible manner compared to glycogen. Overall, it also has a low risk of hypoglycemia compared to glycogen, and it shows significant reduction in the rate of nocturnal hypoglycemia. I thank you for your attention.
Thank you very much for this very illuminating and quite interesting lecture, Dr. Tiase. We're very grateful. I don't know if we have any questions in the chat box from the audience. If they've typed in any questions, I hope you'll be able to take a few for us. Dr. Tiase?
I'm trying to, yeah. So I've gone off now. I can't see, I don't know whether, I don't see any questions. Prince, are there any questions you want to help us? I can't see questions.
If anybody has a question, they are welcome to type it. Dr. Tiase is ready to take questions. Any place you'd like to go over or any point you'd like her to clarify?
It's either I've confused you or I've made you understand. I hope it's not a former.
No, I'm quite sure you made understand. I understand even more than I knew before. Thank you.
So there are no questions. Oh, okay.
Or I hope they are warming up.
All right. We'll give them time.
Let's give it a few minutes. Even if it's not a question, if it's a comment or an addendum, the facilitator is glad to answer.
No questions. Okay.
I guess this means okay, good. Something just came up right now. Hi, Dr. Atiase. How do you make sure the patient does not become hypoglycemic while maintaining a tight glycemic control? Thanks. This is from Hammond Nehemiah.
Okay. Thank you, Nehemiah. I hope you've broken the ice for subsequent questions. Well, if you want a patient to get to target, I would say that don't do tight right from the beginning. Try and get to HbA1c of 7. Usually, for most people, HbA1c of 7 is not so tight. Okay, you get to 7 and you've done so without hypos. And it's important that our patients monitor their blood glucose. Without monitoring, we cannot identify some of these hypos. And now elsewhere, they are not even doing glucose monitoring on the fingertips that we are doing. They are doing continuous glucose monitor. A few weeks ago, I had a patient who we just couldn't get him to, his sugars were all over the place. He wasn't, when he does it, he seems fine, but his HbA1cs are always high. Then he managed to get a continuous glucose monitor patch. We were shocked. At night, every 2 a.m., his sugar was dropping. So his basal insulin, but he would wake up with a sugar of maybe 6.5. And his target was always, we said you can do anything up to 6. So when seeing all the fluctuations, it was only when he got a monitor, the continuous glucose monitor, and I know it's expensive. I think it's over $100 for a little patch that lasts for a few 2 weeks or so. So it's not for everybody. But at the very least, most of our patients should have a glucometer, and we must talk to our patients. Sometimes we just start insulin and we let them go. They don't have a glucometer, they don't even know how to use it. One of the things you have to do with insulin education is to ensure that your patient has a glucometer if possible. If they don't have a glucometer, then it becomes very dangerous because you have nothing to work with. You don't know whether they are getting hypos. Remember that if you get frequent hypos, you get what we call hypoglycemic unawareness. So not every patient or not every hypo episode will also give you the symptoms of hypo for you to decide that, oh, I'm getting hypo. So hypoglycemic unawareness becomes a big problem. In elderly patients or in patients who have had frequent hypos, you don't even have to have frequent hypos. One hypoglycemic episode can tip you into hypoglycemic unawareness. So unless you monitor, you won't know. And I used to have a slide that shows a man digging a borehole in his house just behind his wall. Because he was not monitoring, his neighbor at the same side across the fence wall was digging a pit latrine. And the point is that if you don't monitor, you won't know what is going on. So you have to monitor to ensure that you are seeing the fluctuations, the highs and the lows. Otherwise, the risk become even more pronounced. Thank you.
Thank you very much, Dr. Atiase. This reinforces your message that monitoring is key. And for a patient on insulin, monitoring is also a key part of the therapy they are getting. They need to be checked and know what they are doing outside the fasting ankle. We have another question from Aheto Hubert. Per the discussions, are we to move towards basals more now than our well-known mixed-add insulin?
Thank you, Eliklim, for your good question. So the point is not that everybody should go to basal. There are indications for basal and there are indications for a mixed add. For patients who can afford it, if you are intensifying, you probably will be better off doing what we call a basal bolus. You give them a basal and they inject a short acting when they are eating. That's a basal bolus regimen. But we do know, for example, most of our patients are on NHIs. They can't get some of these things. So pre-mixed insulin has a role. In fact, I have a patient who didn't do well on basal bolus. And the guidelines say that if you choose the basal bolus route and the patients do not do well, consider changing to premix insulin. You may find that they may do well. So your patient must be chosen carefully. But because basal insulins offer a once daily insulin dosing, usually it is easier to break the ice when they are coming to initiate insulin with an insulin shot. And you tell them, oh, it's a pen, the needle is small, it's once a day, just so that they get into the knack of things. And once they're able to inject the first dose, they realize that, oh, it's not as terrible as before. So where they can afford it, you should consider a basal insulin. However, for most of us who see patients who are heavily dependent on NHIs, for example, many of them are doing well on premix insulin. So that is not the point. There are indications or there's a role for premix insulin. If your patient has significantly um, postprandial glucose, for example, you will realize that you cannot do basal. There are patients who, when you do their monitoring, you find that fasting plasma glucose is not so bad, 6.2, but when they eat, postprandial is all over the place. You realize that it is not a basal insulin. Remember that basal insulins fix fasting. So if your fasting appears to be fixed, then that's not the indication for it. So choose your patient individually. Every patient is different. I hope I've answered your question.
I think you did quite well. It shows that individualization of therapy is key. There's one question that just came up now, a comment, but also a question. He says, fantastic presentation. Any change in the guidelines regarding managing gestational diabetes? This is from Blankson Kweku Tando.
Thank you, Dr. Blankson. Well, gestation, I'm not sure what you mean by changing the guidelines. I don't know. The guidelines have remained the same concerning gestational diabetes for a while. We know that when I was in medical school, I was told that metformin was dangerous for pregnant women or for the fetus. It was teratogenic. Now we know that you can do metformin. A lot of patients with gestational diabetes will do well on lifestyle changes, diets, moderate exercise, if they can, if they don't have any contraindication, and metformin. But of course, aside metformin, there are some studies that show that glyburide, I think is a sulfonylurea, glibentamide, has been shown in some studies to be safe. But for most guidelines, and I think the Ghana guidelines, after metformin, if a patient is not well controlled on the maximum tolerable dose of metformin, you do insulin. And some basal insulins are effective and can be used in pregnancy. I know the gynecologists like the premix insulin, but if you read the labels, some of the basal insulin, and you may want to consider reading the labels yourself and making that choice. Some of the basal insulins can be used in gestational diabetes. Thank you.
Thank you very much. Dr. Alberta Amu just put a question up now. Great presentation. Is the targeting for basal insulin different for type 1 and type 2?
Well, the fact is, children, especially in very young children, the targets are very difficult to reach. The targets may be different because the risk of hypo in particular may be higher for them. For children, for example, I find that if you give them basal bolus is better, because you can decide to inject a child insulin and after that they say, I don't eat. What will you do? You've already been you're supposed to inject and wait for 30 minutes before they eat. So if you give them basal bolus, then you can ensure, in a child who can be quite incorrigible, you can decide that after he's eaten or just after he's eaten a little bit, then you can inject his short acting, especially if he's type 1. So the targets are generally not different. We know that for both large trials that have been done, when your HbA1c is above 7, your risk of microvascular complications are high. So generally, where possible, we target below 7 for most people. However, in children, sometimes the targets are increased a little bit because of a child, they are more active, the risk of hypo. So 7 points. But now with glucose monitoring in the West, they've changed their targets for even type 1s to below 7, because you can monitor with the glucose monitoring patch and you can see the hypos. But the fear for a child is also hypo. And so that may affect your targets. But if you can do it right, we have patients who have good glycemic control, but of course there are others who don't. Thank you.
Thank you very much, Dr. Atiase. Thank you, Dr. Alberta, for that question. There's a new question up. Hello, Dr. Atiase. Is Insulin Degludec covered by NHIS? This is
No,
from Abdul Kadir Mohammed.
Abdul, no, it is not covered by NHIS yet.
Okay, another one from Lamptey Richard Odati. Difference between, I assume this is between premix insulin and basal insulin.
So premix insulin, basal insulin is a long-acting insulin that covers you for 24 hours. Premix insulin typically contains, the ones we typically use in Ghana contain an intermediate acting insulin. So it doesn't cover 24 hours, but maybe it will cover you about half the day. So by evening, you should be taking another shot. It's a mixture, that's why it's premixed, and it's been premixed in the factory. It's a mixture of intermediate acting insulin and a short acting insulin. However, elsewhere, and the Novo Nordisk people will tell me, they are premixed insulin with even Degludec, right?
Yes, that would be
Aspart, yes. So you can have
yes with aspartame.
Degludec. Yes, Degludec, and so elsewhere we don't have that. I don't. We don't have that, but you can have even pre-mix with Degludec, and it will be given to the patient. But we don't have that available. The important thing is that pre-mix, as a name, is a mixture of long acting or intermediate acting and a short acting, and it's been pre-mixed in the factory. So it's one vial, you take it. And so as you are injecting, even though you are injecting one injection, you're actually injecting two types of insulin into your subcutaneous space. I hope that answers Richard's question.
Okay, this is another question. Is it possible for a patient to be on only basal insulin? Which situations? This is from Lukman Ahmed Kinan.
It is possible, although it's not the usual, because for type 1, you can't be on basal insulin. I hope I made that very clear. But for type 2, we know that the basic pathology underlying type 2 diabetes is insulin resistance. So often there will be at least metformin in the background, and you give insulin on top. So in some patients, you can have metformin and insulin, if unless the person cannot tolerate the metformin at all. Now, sometimes people start insulin therapy and decide that because I'm giving you insulin, we are stopping all medication. Even with premixed insulin in type 2 diabetes, unless there's a contraindication to the metformin, you must give the patient metformin. Recently, I saw an elderly woman who is on 90 units of insulin alone, no metformin. So I was wondering, when you take it, does your tummy hurt? She says, no, I used to take it, but when my doctor switched me to insulin, she said, and now my sugar became difficult. So we increase. So this is a dose that does it. And one time, one doctor said I should try one tablet of metformin. As soon as I tried it, I got a hypo. So they took me off it. Of course, they'll get a hypo. Metformin is an insulin sensitizer. It ensures that we don't give too high a dose of insulin. So even in type 2 diabetes, when you are seeing your patient or you are switching to insulin, sometimes metformin, unless there's a contraindication, metformin should be there. And this woman, I can assure you that once we put her on metformin, we'll probably slash her insulin dose in half. And that will, because metformin is cheaper, the risk of hypo, on a day that she gets active. So yes, even when you are giving insulin, remember that if a patient is on metformin and there's no contraindication, you should continue that. Thank you.
Thank you very much. The questions are coming fast and thick, despite the slow start. This is interesting. This
Lastly,
comment.
Lisa is asking a very interesting question. Can insulin Ivec in hyperglycemic events? Typically for insulin Ivec is very long acting. Typically for what do you call it? For hospitalization, we use a short acting insulin, regular or short acting insulin for hyperglycemic emergencies. However, when you get to a certain point and you are sure that the ketoacidosis, for example, is settling, the recommendation, I haven't seen IDEC being quoted. It has been shown that glargine, for example, in that instance, can be given as a baseline, background insulin, whilst especially when you want to do sliding scale. Now, sliding scale is being discouraged because sliding scale is not proactive, is reactive. We wait for the person's sugar to get to 12, then we give a shot. Why not be proactive? Make sure that they don't get to 12. So Unfortunately, we have to do that in certain instances when we cannot monitor sugars and all that. And I haven't seen the noble people can answer if they have any evidence to show that IDEC can be used. I know glycogen, when you are, especially in ketoacidosis, when you are getting out of it, you can give glycogen in the background and do your sliding scale on top so that there's no gap in the management.
Okay.
As for the
Okay.
benefit of sliding scale, I don't think that there's, I can say that there's any benefit. But of course, in patients who cannot afford a perfuser, cannot avoid monitoring, and then it's all right to do the proactive way of, and we've done sliding scale for a long time. So I guess.
Okay. Obodai Celestina is asking the dose of Degludec, please, and can we add oral antidiabetic?
So Degludec, I said that you start at 10 units a day. Then after a week, you monitor the fasting. So after 3 days before you see the steady state effect, as I mentioned, after about day 5, day 6, day 7, you will see the effect of that 10 units that you gave. And if you are above within your target, you maintain the dose. If you are above your target, you add 2 units. If you are below your target, you are getting hypos. We say add, take away 2 units. Okay. Of course, we can add insulin degludec and most of the basal insulins to other oral medications. Okay. You can add it to all the medications. I think it was only detimir that cannot be used with GLP-1 receptor agonists, and MPH has not been studied with the newer medications also available. But glycogen, both glycogen and degludec
Degludec.
can be given with oral medications from sulfonylureas to what do you call it, SGLT2 inhibitors, DPP4 inhibitors. You can add them, but you add it, you have to monitor and ensure that you are not getting hypos. It's very important. Okay. The other thing I have seen in the past is some people will start with a basal insulin, then they will switch to premix twice a day, and the patient is still on oral sulfonylurea. Once you switch, you can do sulfonylurea with a basal insulin. A sulfonylurea produces insulin during the day. Most sulfonylureas are taken in the mornings. So if you are given premix insulin and you're giving twice daily insulin, then there's no need, to give a sulfonylurea in that instance. It increases your risk of hypo and danger to the patient. And physiologically, it doesn't add anything to the treatment. So if you are doing premix twice a day, please kindly take the patient off sulfonylurea. But if you are doing basal and you are sure the patient will not get hypos, you can consider that. Thank you. So the dose is 10 units, starting dose, but you can increase it to up to, half the patient's body weight.
Noted. Thank you, Dr. Atiase, for such an insightful presentation. Please, in terms of cost of Degludec, how much is Degludec relatively in comparison with the other? This is from Safo Bright Kwaku.
I don't know the price of Degludec. I know it's more expensive than Glargine, but I have no idea. So maybe if you have a Ghanaian rep on the call, they can answer that. I have no idea.
They will find a way to reach out to Safo Bright offline. I gathered from the presentation that Degludec has a longer duration of action. I assumed that glycemic control will be achieved all day round. However, you also mentioned to give mealtime insulin. This is 1 out of 2. Okay, the second part.
So let
Does
me answer
that,
that. Okay, another question follows. I
not
was
the
coming to say
second,
that I was coming to say that yes, it's a long-acting basal, but remember that I showed a slide to show that basal insulin, even physiologically, is responsible for your fasting plasma glucose and your mealtime, your insulin before meals. And it's flat and is in the background. It will not take care of the glycemic surges that you see when you eat. So it's important if you are getting that. So a patient may need either, if especially if both the basal needs, typically the basal needs will go first. Okay. Basal insulin secretion, when the patient is getting diabetes, for example, goes very quickly. Then postprandial will go. And that is why in the past we will say screen the person using a fasting blood glucose, because it will show quickly. Okay. But if the person is on basal insulin, you've managed sugar, fasting blood sugar is now 5.2, but HbA1c is still 7.8 or 8, then you know that you've fixed the fasting now, but there's something else that is contributing to the hyperglycemia in the HbA1c, and that is probably your postprandial glucose, and so you must handle that as well. And the oral medications that can handle that, maybe DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2, they can all do that. Even sulfonylureas can do that.
Okay, the second part of the question has been answered. So I think we'll take maybe one or two more questions and then we can call it a day.
No, Lantus does not have the same duration and action as Degludec. I think some of you were late on the call. Lantus maximum 24, even that some people say is 23, but some studies have shown 24. But Degludec goes beyond that, over 40 hours duration of action. And that is what we try to highlight this afternoon. Thank you. And both of them are basal insulin, so both of them handle your fasting plasma glucose and your preprandial blood glucose. Thank you.
Thank you very much, Dr. Tiase. I think if there are no further comments, Prince can close the comment section now while we round off. We thank you very much for coming to give us of your time and your knowledge and your expertise. It's been very enlightening and very insightful, as evidenced by the questions. I'm sure a lot of us have gotten enough knowledge to make a change in how we manage our patients for the best. I'd like to thank you so much, and we appreciate you very much. I'd also like to thank the members of the audience for coming in and giving us of their time and listening to us. We appreciate you, and thank you very much once again. I think at this time, let me hand off to, I think, Dr. Atiase, I think we've lost you for a minute. Okay,
I'm
your,
here.
your, your video was frozen for a minute.
Okay.
So thank you very much, Ma. We appreciate you.
Thank you.
If you have any last words for us.
So I know that the management of diabetes is rapidly evolving. You hear all sorts of things, and now it doesn't help that our patients have access to all sorts of information. I think that we should also keep abreast. We must educate our patients well. But I think we have the guidelines I mentioned is on the DEMSOG website. I don't know how many people are on the call. How many people are on the call?
About 810 registered, but I can't see how many are on the call. I think I can get that
I'm expecting
information.
that the website, the DEMSOG website, is going to get so many hits in the next few hours. Everybody, if you don't have a copy, we made it available free. And I think that the guidelines are such that if you read the guidelines, you'll know enough about diabetes to manage your patients well. Thank you. Those are my last words. And I hope that the presentation before also did well for the subject at hand. Thank you.
You did wonderfully well. Thank you very much, ma'am, and do have a great day. Okay.